Okay, so this is a rather complex topic that I knew very little about before I was asked to give it. These are my disclosures, by the way. Now you see them. Oh, God, they got only so many seconds to put it up. Now you see it, now you don't. So what am I going to talk about? I'm going to talk about the targets for immunogenicity, about TNF inhibitors only, factors affecting immunogenicity, the clinical implications of immunogenicity, and finally, can we, pardon me, this isn't tuberculosis, it's not SARS, it's not H7N9, I don't sleep with chickens, just so you know that, okay. But I will be coughing, and my apologies. And there isn't a number there, it's down here. Okay, so proposed treatment algorithm, at the end of the day, that's what I'd like to do. So, because I'm a Canadian, and because I'm a proud Canadian, I'm not an American, I'm a proud Canadian, I just want to show you this one slide that says, immunogenicity of biologic agents, a new concern for practicing rheumatologists. Now, obviously, it was written by a Canadian, Paul Haraway, in Quebec. Quebec is still part of Canada. I wanted to let you know we're still together. And Paul suggested there was an issue with immunogenicity, and he's probably right. So one of the questions is, what are the targets for immunogenicity? I said I was going to talk about that. So these are the targets, and everybody knows them. On the first one, on the left-hand side, of course, you have Etanercept, which is a soluble receptor, and its change from human is probably at the hinge region, where the Fc binds to the molecule itself, or the receptor. And then the next one, of course, is Infliximab, which is about 25% murine protein. I must say, the first time I asked my patient, how did she feel about taking something with 25% murine protein, her answer is, I'm going to be cheesed off. She said it, I didn't. So the next one, of course, is a fully human antibody, which is adalimumab. The next one to that is golimumab, another fully human antibody. And then finally, on the right-hand side, that right-hand side, is certolizumab pegol, which is humanized. It's not the same as human. A humanized antibody with about 4 to 7% murine protein. So humanized is not the same as human. Okay, this is the key point. All anti-drug antibodies are increased with all TNF inhibitors. It's in the label, it's everywhere. It's a given fact that all the TNFs have anti-drug antibodies against them. Now, the next few slides, and there's about 5 of them, are really for visual effect only. You can't read it, I can't read it, I don't care, but I'll tell you what's on it. So this is actually a review, it's a systematic review by a fellow named Vincent, F.B. Vincent, and he really presented all the data on the antibodies, anti-drug antibodies against TNF inhibitors. So there's the slide. I can't read it either. But what it says, first of all, is it points to a number of different patient groups. So it turns out there's rheumatoid, psoriatic arthritis, ankylosing spondylitis, Crohn's disease. That means the antibodies are found in all of these diseases. Then it looks at the percent, and the percent varies from study to study. And then it looks at the relationship between the antibody and the trough level, serum level, the response itself, adverse events, and then the effect of methotrexate on the anti-drug antibodies. That's what all of those columns are. But the important column is down at the bottom in red, in yellow, that says that between 6 and 61% of patients have been diagnosed as having anti-drug antibodies against infliximab in the variety of studies. So, the adalimumab, the same table, this time up to 87%, but notice this is as low as 0.04%. We're talking about huge variability from study to study. And then Etanercept, 0 to 18%. And then we look at certolizumab, for example, at 25% maximum, and then you can see it at the bottom. And then finally, of course, is certolizumab pegol, which about 7.2%. Up till now, there aren't a lot of studies, but at least those are the numbers. So there's some messages. The messages are, number one, anti-drug antibodies are seen against TNF inhibitors in all the diseases where TNF inhibitors are used. Number two, they vary from study to study. Number 3, they correlate and are inversely correlated with the serum trough level, higher antibodies, lower serum level, with the response. Higher antibodies, generally less response, and also with methotrexate, because we all know that methotrexate does have an effect on reducing the anti-drug antibodies. And then the concept is that anti-drug antibodies do have side effects, mainly infusion reactions. And the issue was injection site reactions, and the answer is, I haven't seen a paper yet that correlates anti-drug antibodies with injection site reactions. If someone knows it, let me know at the end of the talk. This is probably the most important slide because this is the complexity. This is the problem with the field. So on the left-hand side, it says factors contributing to immunogenicity. So it's the drug itself, it's the dose, it's how it's given, it's how long it's given, important. It's concomitant medication like immunosuppressants or methotrexate, certainly affected. And then there's a whole host of other things, which is more the basic science, which apparently contributes to immunogenicity. What's even more important is the other side of the equation, the right-hand side, because there we're talking about the clearance of immune complexes of drug, anti-drug antibody, drug, anti-drug antibody. Clearance is very important. The faster it clears, the less effect, obviously. The presence of the drug itself. All or most of the assays to date do not measure the drug and the antibody separately. They cannot separate the drug from the antibody. Most of the assays. There are a few that actually measure the antibody, even in the presence of a drug. Most do not. So the type of detection assay is important. There are two major kinds, the ELISA assay and the radioimmunoassay. The radioimmunoassay is more sensitive, and in fact, it is more sensitive to the detection of anti-drug antibodies and its effect on response. The ELISA is less sensitive. And then obviously the timing, that is the serum, the soluble drug itself. So when you take the sample is critical because if there's serum drug, if there's serum drug, serum, if there's drug in the circulation at the time you try to measure the antibody, it may combine with the antibody and therefore it will not be detectable. So that's critical. And then, excuse me, finally the antibody titer is important. So this is the issue of interpreting the results. So notice there's 3 kinds of results you can have: positive, negative, and I don't know, indeterminate. So the first one is easy. If the antibodies are there, chances are they're at least there greater than the serum level because the serum level did not combine with it, the drug didn't combine with it, and even if it did, you don't know the absolute level because if there's drug there, you just know there's more antibody than drug. That's all you know. That's positive. Then you have negative. No drug level, no antibody. It's okay. And that obviously depends how good the detection system is, both for the antibody and for the drug. And then finally, you have the inconclusive, which is negative for antibodies, but you have drug in the circulation. You can find the drug, you can't find the antibody. So it's inconclusive because it may be, obviously the drug is binding up with the antibody, so you can't detect it. That's called inconclusive. Okay. So this is a sentence by my good friend Paul Harouet from Quebec, who says, and he's the aficionado in Canada on immunogenicity, he says, data on antibody development and immunogenicity are highly dependent on the sensitivity and the specificity of the assay. Absolutely true. The interpretation requires information about the drug levels at the time of the sampling. Absolutely true. Very few assays, which is also true, tell you how they do it. It's not in the public domain, so you don't know what they're actually detecting. And then finally, for these reasons, the comparison of one incidence of antibodies between products and also study to study can be misleading. It is a muddy field, is the point. It's very muddy. Okay, so what am I going to talk about now? I've talked that it's muddy. Yeah, there are issues. Excuse me, I'm going to talk about safety, impact of the antibodies on safety, the anti-drug antibodies, impact on efficacy, impact on dose escalation or vice versa, dose escalation on the anti-drug antibodies, and finally we're going to talk about impact on switching, on drug switching. I do want to make a comment at the beginning. Since the highest level of antibodies have been detected in Infliximab and Adalimumab, and almost all the studies have been done with respect to dose escalation or switching with Adalimumab or Infliximab. I'm going to use those two agents generally to discuss the data. But I believe that the information that you glean from those two are still appropriate to think about with the other agents. Golimumab, for example, certolizumab, they're still appropriate. But most data is with Adalimumab and Infliximab. What about safety? So the first slide here shows you the infusion reaction related to the antibody. So on the left-hand side here in this is the ATTRACT trial, so we're talking about rheumatoid arthritis. Negative antibodies, very little reaction. Inconclusive, almost nothing. And at least 11% of people have infusion reactions when the antibodies are present. And then you look at Crohn's disease, same thing. Negative, nothing much, or some. Inconclusive, nothing much. And twice as many infusion reactions in Crohn's disease when the antibodies are present. That's all you're going to hear about safety. It's clear that antibodies do play a role. And the problem in Crohn's disease was that we in rheumatoid treat people on a regular basis. They treated when they felt like, when there was a flare, of course, they allowed antibodies to form. They had many more infusion reactions than in rheumatoid. Then they suddenly got the light. They are going to do it on a regular basis. And sure enough, the infusion reactions went down dramatically. So they learned from us. As they always do. I hope there aren't too many GI folks here. As they always do. We are ahead of the pack. Okay, so here's the conclusion. Anti-drug antibodies increase the risk of infusion reactions. And as I said, I don't know anything about injection site reactions. What about efficacy? So there was a study, a recent meta-analysis by a fellow named Garces, and he did a meta-analysis of Infliximab, Adalimumab, in multiple diseases, and he asked the question, how much does an anti-drug antibody actually reduce the response? So he has this lovely plot. It's called a forest plot, by the way. See a forest plot right here. And on this side, the further over you go to the left, it means the greater the effect of the antibody in inhibiting the response. Closer to the center line means there's less inhibition. You can see almost every single study shows some inhibition of response by the antibody. On average, there's about a 35% reduction in the response, 35% reduction in the response by the anti-drug antibodies. The other interesting thing is, except for one of these, notice these longer bars are further to the left, here, 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 and there. And those that are further to the left means there's more of an effect. It turns out those are Crohn's disease, psoriatic arthritis, and ankylosing spondylitis. It seems that anti-drug antibodies may have more of an effect on seronegative disease, for reasons unclear to me, than seropositive or rheumatoid arthritis. Okay, now the next slide is wonderful because I absolutely do not understand it. I've read it 6 Ways to Sunday. I've asked 3 colleagues, what do they think? How do you interpret it? Nobody had an answer. In fact, my last colleague said, why don't you just skip it? So I'm going to show it. There it is. And now I'm going to skip it and say, there's the conclusion. Why bother reading it unless someone is really good at this stuff? It says anti-drug antibody response is influenced by methotrexate. It's clear methotrexate lowers the anti-drug antibody response. Also immunosuppression, less so than methotrexate. Rheumatoid arthritis, interesting, it seems there's less anti-drug antibody problems with rheumatoid than with the seronegative arthropathies, spondylitis, psoriatic arthritis. And then the question about initiating a higher dose of the biologic, and that was the confusion in this slide. Generally speaking, they suggest if you initiate a high dose, like 10 milligram per kilogram Infliximab, you dramatically lower anti-drug antibodies. The lower you start, the more chance of having anti-drug antibody, anti-Infliximab. The higher you start, the less likely you're going to have a problem. Unfortunately, the table I just showed you was kind of contrary to that, and if I don't believe the data, I throw it out. That's why I moved on. Okay, now the next issue is, as an example, what does anti-drug antibodies do? Well, one of the things they do is they affect the primary response. A primary failure can occur because of antibodies. A secondary failure classically is thought to be related to antibodies. You do well, then lose the effect, so it's thought to be related. But the other things they can do are, number one, they can affect the survival over time. And number two, they can affect the probability of maintaining or sustaining low disease state of remission. So this is the data I'm going to show you. So these are two curves, survival curves. If you're antibody positive, the dropout rate, this is the dropout rate on the left-hand side, is higher than if you're antibody negative. And the dropout rate, that's just dropout, but if you drop out due to efficacy, again, same curve. It shows that more people drop out if you're antibody positive than negative. So the other question is sustainability of low disease state of remission. So here it is. If you're antibody negative, you sustain people in low disease state. You're antibody positive, your sustain is not very good. And if you're, depending on the dose, if you have, for example, high dose anti-drug antibodies, right here, you actually don't do very well. If you have medium dose, you do better. And if you're negative, you do even better in terms of sustainability. And that's in low disease state. And then remission here, again, antibodies suggest you don't really do very well in terms of sustaining, whereas on the other hand, you do sustain remission if you don't have any antibodies. So that's just two examples, in addition to primary failure and secondary failure, of what anti-drug antibodies can do. So, message. Anti-drug antibodies increase the dropout rate as a consequence of loss of efficacy. That's like the secondary failures. And anti-drug antibodies also reduce the sustainability of low disease state or remission. Okay, what about the effect of serum TNF levels? We're not talking about antibodies now. What's the effect of the serum TNF level on the clinical outcomes? So here's an example. This is in Crohn's disease here. And you can see here, these are people with undetectable serum infliximab. This is detectable serum infliximab. You look at those people that had a reasonably reduced, this is a low CRP, that means that's success. You look at people here that are in remission, more in remission if you have actually a detectable level. You look here and you can say endoscopic improvement, much better than if you don't have a level. And finally here is the complete endoscopic remission, and again, much higher in those patients that you can actually detect the level in than those that are undetectable. So it's obvious. If you can detect it and the level's higher, you're going to do better. That's what it says. Now, that's in Crohn's. In rheumatoid arthritis, for example, if we're looking at the PK and adalimumab concentrations, here what happens if you have no anti-Adalimumab antibodies. So that's pretty good. Your PK is good, you got a high level. If you have moderate anti-Adalimumab antibodies, it drops lower. And if you have very high levels of anti-Adalimumab antibodies, by the way, anti-Adalimumab antibodies, I've been rehearsing all week for this, and I think I've done pretty well. I could have said ADA, but I didn't know whether ADA was anti-Adalimumab antibodies or anti-drug antibodies, so I decided to tell you the whole story. Anti-Adalimumab antibodies. There it is, practiced and rehearsed and succeeded. So that's that. And then if you look at the serum levels in terms of response, you see here that there's not much of a response with low, on average, adalimumab levels. Higher concentration, you have moderate EULAR response, and the highest concentrations of adalimumab show that you have a reasonably good response. So, you know, it doesn't take a rocket science to say that you have a better response when the adalimumab, than a TNF is higher, the serum is higher. And it doesn't take a rocket scientist to say the higher the antibodies against the serum, the less likely the response. So that's kind of what I call rocket science. Now, again, we talked about Crohn's, we talked about rheumatoid. Now we're going to talk about psoriasis. Even in psoriasis, this is adalimumab serum levels. And so if you have low serum levels, you have a very poor response. A PASI response is poor. If you're a moderate responder, the levels are higher. And good responders, on average, if you look at the range here, it's even higher. Again, it says there's a direct correlation between the serum level and the PASI response, as well as Crohn's, as well as in RA. So, ankylosing spondylitis. You've got a whole group of people that are non-responders. You have a group of people that are responders. And there is indeed a difference between responders and non-responders in relationship to infliximab concentration or infliximab level. The higher the level, the more responders. The lower the level, the fewer responders. Again, not exactly rocket science. All right, and then we have Etanercept. Now that's kind of interesting because I threw up Etanercept here because there was no relationship between the serum level and response with Etanercept. Here's Etanercept. This is the ASIS responders. So this is ankylosing spondylitis. And notice the level in non-responders was essentially the same as the level in responders. So apart from the antibodies, which actually did show something, these did not actually show very much, at least in terms of Etanercept. There was no relationship between the trough level and response. So what's the message? Serum trough levels of adalimumab affect the clinical outcomes in RA and non-RA conditions. Whew, that was rocket science. And the trough levels of Etanercept, though, do not affect, at least in one study, did not affect the clinical outcomes. Did not. So now we move on and we say, okay, what's the impact of either dose escalation on anti-drug antibodies or anti-drug antibodies on dose escalation? So the concept is, if I have anti-drug antibodies, does escalation make a difference? Can it help if I escalate the dose? And you all know there's really only two TNFs you can escalate, essentially. One is clearly Infliximab, and some people, 20% of people, escalate the dose of Adalimumab if you can afford it because it doubles the cost, of course. Okay, so here's an area of Crohn's disease, and these are folks that have detectable anti-drug antibodies. So they say, okay, here's detectable anti-drug antibodies. I'm going to see if I increase the dose of Infliximab, if I have anti-drug antibodies, will I have an improved response? And the answer is not likely. On the other hand, if I have antibodies against Infliximab in Crohn's disease, if I change the TNF, and remember, critical point, that there is in fact not a cross-reactivity in most cases between one antibody and another. There is not cross-reactivity between one and another. There are a few cases where if you had an allergic reaction to adalimumab, you switched to Etanercept, you did have an allergic reaction, for example. Very, very uncommon. Uncommon. So cross-reactivity doesn't exist very much, but these are people that have antibodies against Infliximab. What about if you just look at the concentration? Because remember, you can look at this concentration, or you can look at the antibody levels. So here's a concentration issue. You have subtherapeutic concentrations of Infliximab, whatever they are in Crohn's, and you say, okay, I'm going to increase the Infliximab dose. Sure enough, there's a really good response. A higher percentage of people respond if you increase the dose, if you knew that you had a subtherapeutic dose. And if you change the anti-TNF, nothing much happens. So it becomes clear that the antibodies and the serum level actually can give you a message as to what to do next, potentially, at least if you can dose escalate. Excuse me, but there's a caveat to that. That's the but. You see the yellow but there? That's the caveat. So dose escalation is useful in patients with subtherapeutic doses, right? Low concentration, dose escalate. Dose escalation is unhelpful in patients with detectable anti-drug antibodies, and if they have therapeutic levels with antibodies, why bother? Dose escalation is not going to help. However, here's the however. There are some reports that even when you dose escalate, you actually boost the immune response and you actually increase infusion reactions. So the concept was I can increase the dose and not only have more of a level, but some people said if I increase the dose, I might reduce the antibodies. I might actually have an effect on the antibody itself and reduce the antibodies levels. However, some people get worse, and then the next line says, while others report that show a decrease in the anti-drug antibodies when you dose escalate and you improve the drug response. So do we really know? Do we really know by increasing the level where you're going to have more problems or whether or not you're going to improve? The answer is not necessarily so. So dose escalation, at least in our diseases, is still an issue. It's a question. So more studies are clearly warranted. Now, this is probably the most important part of the whole scenario in terms of anti-drug antibodies. So it says, what's the impact of anti-drug antibodies in terms of TNF switching? That's the question. So this is a lovely study by a fellow named Bartholds. And what he did is he took 235 patients, and 20% of those, he switched to adalimumab. They went from infliximab to adalimumab, and then the others remained on infliximab. Or at least they were naive to the TNF. So some had previous infliximab, some were naive to a previous TNF. Okay, get it? Some previous naive to a previous TNF, some, 20%, already had infliximab and then went to adalimumab. And so his question was, number one, what's the anti-Adalimumab antibodies in those populations? Is there any difference in the anti-Adalimumab antibodies, one, if I'm naive to a previous TNF, or number two, I already had infliximab and then went to adalimumab? Was there a difference in the anti-Adalimumab antibodies? Because theoretically, if you have more anti-Adalimumab antibodies, you're not going to do well. So here's the data, and it's in that red circle. So the first line of that circle says that's the anti-Adalimumab antibody levels, and you see in the anti-TNF naive patients, so they didn't have infliximab, 18% of patients on adalimumab, excuse me, had antibodies. But if you previously had infliximab and then went to adalimumab, 27% of patients now had anti-adalimumab antibody. And I told you there's no cross-reactivity. So theoretically, just because you had antibodies against infliximab, it shouldn't automatically mean you got antibodies against adalimumab. And then, this is over here now, these are people with antibodies against infliximab. Now you're up to 33% of patients who had antibodies against infliximab, who also, when you used adalimumab, had antibodies as well. It kept going up. And what happens then if you had infliximab before, but you didn't have any anti-infliximab antibodies? You had no antibodies against infliximab. What happens to the antibodies against adalimumab? It comes back to normal. So this line basically says that if I've had infliximab before adalimumab, a portion of the patients are more likely to have anti-Adalimumab antibody. That's what it says. Now down here, if we're looking at the DOS response, you know, was is DOS? This is DOS, DOS 28. This is the was is DOS 28 response. And what they're asking is, how did you do, for example, if you're adalimumab negative, you don't have any anti-adalimumab antibodies, what's the DOS change like? And it was 1.8, which isn't great, but that's okay. It was 2, 1.3, 1.6. But suddenly here, there was a group of patients who had a very poor response to adalimumab after they had infliximab. And who are those patients? Those were the patients who did not have anti-infliximab antibodies. So if you had anti-infliximab antibodies, you still did okay, except for those few patients that might have had more anti-adalimumab antibodies. But in general, you did okay. But if you had no antibodies against infliximab and then used another TNF, namely adalimumab, you did very poorly. So the message is there's an increase, supposedly an increased likelihood of anti-adalimumab, this is one study, possible increase in anti-adalimumab antibodies in patients who had a prior anti-TNF, mainly infliximab. The thought is maybe, the GI people believe this, there are people called rapid metabolizers. So the person had a TNF before and he was rapidly metabolizing his infliximab, and then when you use adalimumab, they were rapidly metabolizing the adalimumab because they're rapid metabolizers, and if the serum level goes down, you increase the risk of antibodies, so that low serum level plus increased antibodies is an effect. Now, adalimumab switchers after infliximab who did not have any antibodies against infliximab had a reduced response. So, anti-adalimumab switchers after infliximab, am I finished already? Am I already done? My God. But you know, I started 5 minutes late, by the way. Did you know that? You give me 5. Okay, I'll talk quickly. They call me Fast Eddie. Adalimumab switchers after infliximab with anti-infliximab antibodies had a good response. So if you have antibodies against infliximab, you'll do okay with adalimumab. These results obviously have implications in terms of choice. So here's an example. A TNF naive patients, they have a good response. These are switchers from a TNF, namely Infliximab, to Etanercept. The Infliximab had antibodies against Infliximab, still good response. This is an Infliximab patient who did not have antibodies, and the next TNF did poorly. So if anti-drug antibodies are present to the first TNF, consider a second TNF. But I'll forget that line. But if there are no anti-drug antibodies to the first TNF, consider a biologic with a different mechanism of action. So no antibodies against the first TNF, maybe you should use a different mechanism of action. And I say, nice thought, but very interesting. There is no comparative data to date on the response of a second TNF to that of a biologic with a different mechanism of action. So in other words, whether you had antibodies or not, no one has compared a TNF response to a biologic with a different mechanism of action, let's say tocilizumab, abatacept, or rituximab. No one has carried out that study. We all say you should switch to another mechanism, but there's no data. There is no data. So, take-home message. Serum trough levels may be helpful in treatment decisions in terms of dose escalation or switching. Anti-drug levels may be helpful in treatment decisions to switch to another TNF or a non-TNF, and one can construct an algorithm to whether if you're monitoring serum and drug levels. And of course, is there an algorithm? Yes. Here's the algorithm. I failed a TNF. I measure concentration of the drug. I measure concentrations of the antibody. If the antibodies are negative and it's a suboptimal TNF level, obviously increase the dose. If there are antibodies present, no matter what the drug level is, it says switch to another TNF. Switch to another TNF if there are antibodies there. And if there are no antibodies, even if you have an optimal level of the drug, but no antibodies, switch to a biologic with a different mechanism because it means you're probably TNF resistant. You didn't have antibodies. The reason you didn't respond is because TNF was not a major part of that person's inflammatory response, supposedly. So, at the end of the day, although immunogenicity may help explain clinical outcomes, its role in clinical practice still remains unclear. More prospective data is needed. And I must say the GI folks have really got on the wagon. They are using serum levels of Infliximab to make all their decisions, or many of their decisions, about what they're going to do with Infliximab. Rheumatologists are not there yet. We don't measure antibodies very often, but theoretically, it could be helpful. Thank you very much.